look after these patients. Unfortunately, I had a PowerPoint that was ready, but I couldn't find it today, but we don't need it really. I like the whiteboard better because I think it makes the information stick more. So I think the first thing we need to talk about is what is ovarian hyperstimulation syndrome, okay? So ovarian hyperstimulation syndrome, I will tell you the definition so you know it clearly. It's an iatrogenic complication of ovarian induction. Okay, that's very simply put what it is. Most of the time, over 99% of cases happen because you gave the patient something to induce ovulation, and then she developed this complication later on. The reported incidence depends on the study you look at. If they ask you in the exam, what is the incidence of ovarian hyperstimulation syndrome? Overall, you can say about 10%. If they ask you globally, what is the risk? But if they want more details, the incidence of actually mild ovarian hyperstimulation syndrome, or the syndrome that we see on daily basis during our practice, it is about 20 to 30%. So in the ballpark, so a third of our patients will develop mild hyperstimulation. And it is wanted hyperstimulation because it is called, actually, when we do ovulation induction, the other name for it is controlled ovarian hyperstimulation. The mild hyperstimulation is in the ballpark of about 5 to 10%. The severe case, luckily, alhamdulillah, is 1 to 3%. And the goal is that we have to eliminate the 1 to 3%, okay? So before we dig deeper into ovarian hyperstimulation syndrome, we talked about this yesterday, and I told you you have to understand and should be able in the exam to list the risk factors for ovarian hyperstimulation syndrome. So volunteers, I need somebody to start listing them for me. You can, the way that I run my talk is anybody can unmute the mic, or I'll start picking names. I don't know all of you, but anyone who's willing.
Young.
Okay, so young age, okay? Young age, when we talk about young age, we're usually talking about patients below the age of 30. So any patient below the age of 30,
previous history.
Right, so please remember this point. Any patient, when they ask you in OB-GYN, for OSCE exams, in oral, whatever it is, previous same thing will lead to the same thing again in the future. Previous IUGR, whatever it is.
Intrafollicular count.
Very high antral follicle count. Okay? So high. So that's why doing an ultrasound to measure antral follicle count is very important when you start your ovulation induction, because you might see the cycles are run different everywhere in the world. Okay. For example, I'll tell you the way it is run here in Saudi. It is physician dependent. Maridat Ayman Orif, or patient of Dr. Ayman, will see Dr. Ayman to start her stimulation. In developed countries like Canada and the US, it is different a little bit. Over there, I decide that this patient needs IVF. I put a protocol. This protocol goes into queue. It goes into a line waiting to start IVF. She might not start until 2-3 months until her line comes up. At that day, the physician on call, which might not be Ayman Orif, it might be somebody else, will look at the file and sees Dr. Ayman wrote 300 of FSH. He looks at the AFC on that day and he sees it's 30. That day, they will adjust the FSH on the day of stimulation, because on the day that I wrote the protocol, I might have been busy, I just did not pay attention. So that's why doing antral follicle count on the day of start of stimulation is very important. So high AFT, غيره.
Very thin patients.
Very thin patients, okay? So thin patients, not very thin, thin. Okay, so low BMI, if you want to be scientific. Low BMI, because they're very sensitive to whatever FSH you give them. What else?
High estrogen.
High estrogen.
So
estradiol more than 10,000.
PCR. So let's explain estradiol greater than 10,000. Estradiol greater than 10,000, this is during stimulation, okay? So you picked up the dose and the patient is in the middle of the cycle. Every time she comes for ultrasound, we measure her estradiol level as well. So this is something that's probably not that preventative. All of these, we can prevent it by reducing LFSH, but however, this factor, you're already, you started the wheel of ovarian hyperstimulation. She's in stimulation and she's flipping into ovarian hyperstimulation. What else?
High dose of gonadotropin.
Right, you wrongly chose the dose of FSH, so high dose of FSH for the patient, okay?
Polycystic ovarian syndrome.
PCOS is a very one. What is the protocol that we did not explain yesterday? And we explained the antagonist protocol. The other one?
Agonist.
Yeah, being on a long agonist protocol puts the patient at higher risk of ovarian hyperstimulation. Please, I beg all the residents, you have to be able to mention these. You have to understand why they are risk factors for ovarian hyperstimulation syndrome. Okay, I'll leave them on the board. We'll put another text box here. Now, everybody understands the menstrual cycle. Is anybody in the audience does not understand the menstrual cycle? If you understand the menstrual cycle, you will not understand the IVF and hyperstimulation. Does everybody understand the menstrual cycle, or do you want me to explain it briefly here? Do we have any R1s in the audience? Any residents in the first year of training? Okay, so I'll probably explain it for the R1s. The seniors can tag along and they can refresh their memories. So when you look at the menstrual cycle, okay, there is the pituitary part, okay? There is the ovarian part, and there is the uterine part, all right? This is how the menstrual cycle happens. So in the pituitary part, the FSH, when the woman is menstruating, so here, if we draw a line, the woman in these days, she's menstruating the first 4 or 5 days of her cycle, okay? During this part, estrogen is low from the previous cycle. It fell down, if you remember. FSH was, this is FSH, okay? FSH was under constant suppression from the high estradiol of the previous cycle. However, because of the drop in estradiol, the FSH gets released from this inhibition of the estradiol. So what starts to happen here is FSH starts to rise, okay? When the FSH starts to rise, the follicle, the ovary will respond. هيجوا هنا مجموعة follicles. If you remember, I said before, there is a cohort coming together, 10 to 15 follicles. This was predetermined 3 months before. The ovary says, okay, guys, in the next 3 months, after 3 months from now, this group of 10 follicles will go and the good one will win the race, okay? So in response to this rising FSH, this is what we call the FSH window, okay? FSH window is the level of FSH that each level, each follicle requires to become the dominant follicle, okay? You have to understand this concept. So this follicle probably needs 1 day of FSH. This follicle needs 3 days of FSH. This follicle needs 6 days of FSH. This rise of FSH of 1 day will recruit the strongest follicle, and this follicle from the granulosa cell will start producing estradiol. So your estradiol now starts to rise. When you have the rise in estradiol, what it does, okay, what it does to the FSH, it causes negative feedback and it goes back down. The estradiol continues to rise because the follicle continues to develop from the granulosa cell, okay, and it becomes the dominant follicle. Mid-cycle, okay, so mid-cycle here, about day 14, we're talking about women with regular cycles, okay? Whoever's mic is on, please mute your mic, okay? In natural cycles, at certain levels of estradiol, this will trigger, please somebody mute your mic. I don't know who it is, please mute it. I hear kids in the background. At certain level of estradiol, once it reaches a certain level, and most of the time we think it's 500 millimoles, okay? This will trigger what's called the LH surge, okay? We don't know until today if the LH surge causes ovulation or ovulation causes LH surge. It's not clearly understood, okay? And then the estradiol starts to plateau here, but your FSH is still low, okay? The rising estradiol here changes the uterus from menstruating to proliferative phase, okay? Cellular proliferation. Once ovulation happens and your progesterone rises, okay, the dominant follicle becomes the corpus luteum, and it continues because of the progesterone is produced from the corpus luteum, and this transforms the the endometrium into the secretory phase. ليش؟ عشان if the woman is destined to become pregnant, this is the most receptive to the embryo. After a while, the corpus luteum, if the woman does not get pregnant, dies. Your estradiol drops, your progesterone drops, okay? And then the woman will start menstruating again, and the cycle continues again. When you are doing IVF cycles, okay? When you are doing IVF cycles, the most important thing for you to understand is we are the pituitary gland of the patient. We eliminate the pituitary gland of the patient. Even though the estradiol is rising, this will not cause the LH surge of the patient, okay? This will not cause the LH surge of the patient. Why? Because the GnRH antagonist that you added on day 5 or 6 of stimulation somewhere here will prevent this surge that happens. So although the estradiol is rising, what's happening with it, okay? The FSH is also continuing to rise because you're giving it as exogenous to the patient, okay? And this will rescue all of these follicles that we see here. You're extending the FSH window. You're telling all of these follicles, okay, now you need to grow, okay? Is this understood to everybody? Clear? All right, good. So this is the menstrual cycle. So let's use the eraser. Let's erase this. Sorry, let me just clear everything. So in the natural cycle of IVF, if you remember, sorry, let's draw a line here. Your FSH, the one that I just showed you, is always high. You don't get the drop in FSH. And this will lead to multifollicular growth, okay? So the ovary will have, instead of 1 or 2 follicles, it will have 5 to 10 follicles growing, depending on her antral follicle count. And if you remember from yesterday, the theca granulosa cells, the granulosa cells, on top of producing estradiol, okay, they produce what's called VEGF, vascular endothelial growth factor. And that's probably what leads to nourishment of the underlying endometrium. But if you get too much vascular endothelial growth factor, the woman will flip into ovarian hyperstimulation syndrome. And that's where we said estradiol level above 10,000 will lead to ovarian hyperstimulation syndrome. So if they ask you what is the underlying pathophysiology of ovarian hyperstimulation syndrome, it is vascular endothelial growth factor production, and it gets produced from the granulosa cell of the ovary. Okay, what does vascular endothelial growth factor do? Okay, so it gets produced. So what, is it important? Yes, it is. Okay, vascular endothelial growth factor increases capillary permeability. Okay, the increasing capillary permeability will lead to third spacing of fluid. Okay, so fluid inside the vessels will go into the third space, into the connective tissue. So you get the pulmonary edema, you get the ascites, you get the lower leg swelling, and it's an ongoing process. It does not stop, okay? It is reversible, self-limiting. At one point it will stop, but the woman will continue to get severe in one condition. Does anybody know when it will continue to get worse? So the reason why vascular endothelial, she gets pregnant, right? So everybody said it. The reason why vascular endothelial growth factor gets increased, okay? We think right now from our studies that HCG that we give these patients, the HCG is the factor responsible for the production, the massive production of vascular endothelial growth factor. So if you give HCG for trigger, okay? And the patient is at risk of OHSS, but she's still not in OHSS, you will put her into OHSS. And if you do the transfer and she gets pregnant, her OHSS will definitely get worse. Okay? So that's why in some patients, we'll talk about strategies to later on, which is important for you to know also, to reduce the incidence of OHSS. Okay? Now, So if you have a patient, okay, you're stimulating her, and during her stimulation, you saw that she has a high antral follicle count, her estradiol is high, and she's nearing the end of her stimulation. The question that they might ask you in the exam, what strategies can you do to decrease OHSS or eliminate OHSS, which are very effective and science proven? So one, I saw here, so you can do coasting, okay? So what does coasting mean, okay? Coasting, the patient is receiving FSH every day here, okay? And on this day, day 8, you found out that, oh yeah, this patient is at risk of OHSS. So what you do at this stage, okay, is you stop the FSH only, okay? You stop the FSH only. You do not stop the antagonist or agonist that she's using. You only stop the FSH, and you allow her to continue for a few more days without FSH. So you let the patient go for 2-3 days, and then you bring her back here, okay? And you bring her back here and you measure the estradiol again. You'll see a slight drop, it's okay. Somebody wrote here, I noticed lowering LFSH. Lowering the FSH is detrimental to the cycle, unfortunately, and those patients will not do very well. So coasting is number 1. 2, you can cancel the cycle altogether, especially if the patient has multiple follicles growing. Canceling the cycle means you tell the patient, do not take anything, to stop your antagonist, stop your agonist, stop your FSH, avoid intercourse, which is very important because if she ovulates those eggs, she might get pregnant with multiple pregnancies. So that's option number 2 for these patients. Option number 3 is you trigger with, if in an antagonist cycle, sorry, so if you, that's why it's advantageous, that's why there's an advantage to putting patients in antagonist cycle. In antagonist cycles, okay, you trigger with agonist, okay? So you give them decapeptyl 0.2 milligram, okay? The reason why this works, okay, it causes the endogenous flare of FSH and LH, which will lead to mild increase in LH, mild increase in ovulation. So you get a less number of eggs when you do this, but you prevent the patient from flipping into OHSS, okay? So that's another thing you have to remember. Another thing, if you decide to go ahead to retrieve the patient, you can do what's called freeze-all, okay? So you collect the eggs, you inseminate the eggs, an embryo form, you freeze them. And you tell the patient, I am not going to return the embryos to you. Lesh, why do we do this? We do this to eliminate the rise of HCG, which will lead to worsening of her OHSS. Okay, supportive therapy. So you have to know these, huh? Other therapies that you can do is cabergoline, okay? Cabergoline is a dopamine agonist, okay? And it leads to the mechanism that it works. It suppresses FSH and LH production, but it also suppresses, the most importantly, it suppresses vascular endothelial growth factor production. Dopamine agonists, usually we give the dose 0.5 milligram, 2 hours before the trigger, okay? So before you trigger the patient, you tell her start taking cabergoline once a day, and she takes it for a total of 8 days. Anybody knows why it is 8 days? Can anybody, it's a very stupid reason, by the way. Because IVF doctors, they're not that smart. Because the package of cabergoline contains 8 pills in it, okay? In reality, she can take it only 3 to 4 days, but we want to give her the maximum benefit of it. The box has 8 pills in it, might as well finish it, okay? Next, what else can you do? So you can give them aspirin, okay? There are some studies that show that if you start aspirin on the day of trigger, you can decrease the incidence of OHSS. Okay. Another thing that recently studies have shown, you can give calcium gluconate. Calcium gluconate is another, you give it as an IV infusion, okay? And this has been shown to reduce the incidence of OHSS. Everybody understands this? You all can name it? Move on.
Sorry, doctor, if you can go back to the third point for the antagonist cycle, if you don't mind.
Right. So in antagonist cycles, what we do for these patients, okay? Let's say she's ready here, okay? She's ready here, okay? Rather than giving her HCG to trigger, ما تعطيها HCG, okay? What you give her is you give her a GnRH agonist, okay? تقول لها استمري على ال FSH ولما when the time for triggering comes, okay? When the time of triggering comes, you give her decapeptide 0.2 milligram once, okay? The reason why we do that is you allow the endogenous, they get the flare effect, and the flare effect will lead to ovulation. The downside of it, you get less number of eggs because you don't get a massive amount of HCG to allow the ovulation of all the follicles that are growing, okay? Now, the other thing, let's go to, is this clear? Can I move on? Okay.
Yeah, sure. Thank you so much.
So what are the symptoms that these patients present with? Okay, they will come to you. You either pick them up during their stimulation, okay, or the other thing is the patient will come back to you after after the retrieval, complaining of symptoms. What is the most common symptom that these patients come? And I've seen people have written it. It's abdominal pain. Abdominal pain from the distension that they complain of. The other symptoms that they can complain from is shortness of breath, okay, weight gain,
Nausea, vomiting.
Weight gain, nausea and vomiting, okay. What else? Oliguria, so they're not peeing. They tell you, I'm not peeing, doctor. These are the main symptoms. Sorry?
Breathlessness.
Yeah, shortness of breath. That's shortness of breath, okay. So these are the most common symptoms. The most common one is the abdominal pain, okay. When we work up these patients, okay, you have to categorize patients into mild, moderate, and severe, okay? Severe definitely needs admission to the hospital. Mild and moderate, you can manage them as outpatients, okay? So how do we do that? So the first thing is you go by symptoms, okay? Symptoms. Patients with mild abdominal pain that is managed with pain control, no other symptom, we do an ultrasound for them. If the ovarian size is less than 8 centimeters, okay, excellent. People have written the article, I've shown them, and very mild fluid in the abdomen, okay? What we tell these patients is you can manage them as an outpatient. If you are in a well-established IVF unit, you have an educator, or as a physician yourself, you keep contacting the patient on daily basis for the next week or so. You ask her you ask the patient at home to weigh herself, okay? To monitor her input and output. You tell her to drink a lot of fluid. So usually what I tell them to drink is electrolyte-rich fluid. طبعا موجود في السعودية. It's available in Saudi Arabia, but it's also available readily. Any electrolyte-rich fluid, it's called Gatorade. Gatorade has a lot of electrolytes, so it helps correct any imbalance they have, and it is good for the nausea and vomiting. They're able to tolerate it over regular water, okay? So this is what we do for mild and moderate. It is supportive care. You give them analgesia. If they need anti-nausea, you give them. However, if a patient presents, these are patients that we see in clinic. How about if the patient comes, please do not write on the screen, okay? Whoever is writing on the screen, unless it's Dr. Haytham, it's not acceptable, okay? For patients coming to the ER, okay, you have to understand, so you take history from the patient. When you take history from the patient, important points that you need to ask, okay, of course, is the age, because that will tell you if she's at risk for OHSS. You need to ask her about the dose of FSH that she received, okay, and during her stimulation. What type of trigger did she receive? Did she receive HCG, or did she receive GnRH agonist? Okay. How many
Number of eggs
How many
retrieved.
eggs was retrieved? Okay. When was the procedure done? Because usually this is prevalent in the first 24 to 48 hours after retrieval. Okay. You have to ask her about the symptoms that she's presenting with. Okay. You look at, the patient will not know, but you go look into the file at the estradiol level on the last day of stimulation. Okay. What else do you ask about? Very important.
If diagnosed PCO.
Right, so if she's PCOS or not. Okay, so this is just from the history. On
If she's pregnant.
Well, not pregnant, sorry, this is an important point. If she had an embryo transfer or not. Okay, if you remember, these patients, they usually present 24 to 48 hours, or they can present late. يعني كانوا mild hyperstimulation. The doctor gave them returned the embryos. She went home 2-3 days after, or a week after the embryo transfer, she came back to you complaining of the symptoms. And this is because of the ongoing HCG production. The issue is, if the patient had the transfer a week ago, you will not be able to know if she's pregnant or not, because we said it might be the HCG trigger that's causing the positive HCG in the blood, or she's truly pregnant. So HCG is not that important. So whether or not she had the embryo transfer and whether or not she's pregnant, okay? So this is what you need to do on history. On examination, okay? The most important thing is vital signs, okay? Namely O2 sat, okay? So don't forget to say, when you're in the OSCE exam, please do not say, I will check her vital signs. Say, I will check her vital signs, including blood pressure, temperature, pulse, respiratory rate. All of these will be counted in some exams as 1 point. But if you say vital signs, you might not get the point, or the examiner, if they're tough, they might just give you a part of the point. So you have to mention them all, including O2 saturation. You do a chest exam in these patients, listening for any crackling in the lungs from the pulmonary edema. You then do abdominal exam, okay? In the abdominal exam, you're doing a few things. You want to measure the abdominal girth, okay, which is very important. And you're checking for ascites by doing shifting dullness, okay? You can check the lower limb for the presence of any edema, okay? So this is what you do on physical exam. And these are the points that you'll get in the station in the exam. And this is what you need to do for any patient you are seeing today in the ER for ovarian hyperstimulation. The next question is, what investigations will you order for this patient, okay? So the investigations, this is what you write, okay? You will check CBC. What are you looking for in CBC?
Hematocrit.
What, is it gonna be high or low in these patients?
High.
High.
Right, they're hemoconcentrated, so they will have high hematocrit, okay? Above 40, it's concerning. What else? Leukocytosis, huh? High white blood cell count. Because white blood cells are acute phase reactants. So when a patient is in hyperstimulation syndrome, it's an acute phase, acute stress, acute insult to the body, the white blood cells go high. Check electrolytes, okay? You're checking for namely sodium and potassium. They usually have hyponatremia and hyperkalemia, okay? You check renal function test and you check liver function test, okay? Because if these patients are dehydrated, okay, they might have acute liver or renal injury from the dehydration that they go into, okay? Other thing you ask for is chest X-ray, looking for any pulmonary edema or pleural effusion, and you ask for
ultrasound.
Pelvic ultrasound, okay? I don't usually, a question came up, do I ask for coagulation profile? I don't routinely do it because it's not helpful for me in these patients. You can say it, you're not gonna be faulted, but it's not part of the routine care for these patients, okay? When do we decide that the patient is in severe OHSS? If she has any pulmonary symptoms, okay? If she has, please, whoever's mic is on, turn it off. If she has any pulmonary symptoms, or she has massive ascites, significant ascites, okay? or if she has any renal or liver injury. Okay. So shortness of breath comes with hypoxia. Okay. And then the other thing is the ovary is more than 12 centimeter in size. Okay. So these are the criteria that this patient will need admission to the hospital and for supportive care. Remember, the management for these patients is supportive. There is no actual treatment for them. So what orders are you going to write for these patients when they are admitted? First of all, for diet, are they going to PMPO or they're going to eat? Okay, so we go to the left side, which left side of the orders, but then on medication, we write it later on. So diet as tolerated. I usually like to check the vitals for these patients every 8 hours, depending on the severity of the situation. Okay, so vitals Q 8 hourly, and activity as tolerated. You do not need to put these patients at bed rest. The more they move, the more the chance that the fluid might move back into the intravascular space. The other thing, I ask for daily blood work in these patients. So on daily basis, you check her red blood, CBC, renal function test, and liver function test. The other thing, daily abdominal girth. Okay, you check daily abdominal girth. Okay, for the patient, the nurse has to check her abdominal circumference on daily basis. Strict input-output chart. So you have to know how much the patient has received for fluid and how much she is putting out. You do not need to put a Foley catheter. They can pee in a measuring pan and they can measure it for you, unless the patient is not mobile. She's so much in pain that she's not able to move. Then you tell the patient, you tell the nurse to put a Foley catheter to measure it, okay? So this is what you need to write for them. Let's go to medications that you write them. The biggest mistake that I see most patients, that most residents do, and somebody wrote it already here, you never bolus these patients. You never put them on high maintenance dose. Whatever fluid you give them, they're gonna throw it into the third space. So you're making their condition worse, okay? So what I usually do, okay, you can give them, crystalloids is equivalent to colloids. You do not need to be very specific. What I give these patients is any kind of intravenous fluid. What I give them is D5.5 normal saline, okay? And the rate I put it at is 50 cc's, not more than 50. The reason why I put it at 50, it's enough to keep the vascular space expanded, but not too much so that she will get into worsening of her ascites or worsening of her pulmonary edema. The other thing you need to give them is thrombophlaxis. They are at very high risk of developing DVT, these patients. So usually you can start them on low molecular weight heparin. I usually give these patients Clexane or whatever heparin. So you just say heparin for the exam purposes. And you don't need to give them therapeutic heparin. It depends on the BMI of the patient. The dose can range anywhere between 40 to 80 depending on the BMI, and there's guidelines for that, okay? The other thing, you give them antiemetics as needed, not regular, okay? And you give them analgesia as needed. Be very generous with these patients for pain. They will be very grateful for you because their ovary is bleeding, okay? The ovary itself is full of blood, and that blood will give the patient peritonitis. So if you give them good analgesia, the patient will be comfortable, and inshallah, her recovery will be quicker. Now,
what kind of analgesia we're talking about here? How far?
I usually give them morphine. Okay, I give them 10 milligram morphine, and I give it every 8 hours, or whatever your hospital is comfortable with. Okay, whatever your hospital provides. That's how strong they need it. You can give them tramal, you can give them oxycodone, whatever you want to give them, you can give them. Don't forget to write cabergoline for these patients. So if she's not already on cabergoline and she comes to get admitted, you can write cabergoline. Cool. The last thing, volume expanders like Voluven, all of those, or Pentaspan, these are volume expanders. These patients, multiple studies have shown that they do not benefit from it. There is no role for them in them. The question that comes again is albumin, okay? Now, in Canada, so this is where the dilemma comes. Do we give them albumin or we don't give them albumin? Albumin is a blood product, okay? Albumin, if you give these patients albumin, you are putting them at risk for a transfusion, just like you're doing a blood transfusion. Studies have been mixed. Some studies have showed some improvement, others haven't shown. So in the exam, you can say, I will consider giving albumin. Okay, you can give them 250 cc's over, half an hour, whatever it is. I do not give albumin personally, but in the exam, please mention it because it might be a point on your exam. Now, do not forget the Rutile support if she had her pregnancy, if she had her embryos transferred. Okay, and this is another common mistake that I see patients, residents do. If she had her embryos transferred and there is a possibility she's pregnant, please give her the Rutile support so that the pregnancy will continue. Another important point I forgot here is no NSAIDs. Okay, non-steroidal anti-inflammatory is contraindicated in pregnancy, and you all know why. Now, the other thing that you can do for these patients is two things. If she has massive ascites, okay, and I'll tell you my cutoff. If it is more than 1 liter, estimated by ultrasound, I usually tap these patients, okay? The tap can be done by 2 methods. You either put a pigtail, and this is done by radiology, okay? So they go to the radiology department and they put in a catheter that stays in, or if you're in a center that is capable, you can do transvaginal aspiration, and you can do it every 2 to 3 days, okay? The thing is, you don't want to suck all of the fluid out. This fluid is rich in protein, okay? So if you suck it all out, the patient might feel yucky because of all the protein that you sucked out of the patient, okay? If she has a pleural effusion with hypoxemia, you might consult your colleagues in chest medicine to put a chest tube in. This is very rare, but it can happen. Now, if the patient, most patients will flip around within 48 hours. They will improve, symptoms will improve, and you can send them home, okay? Some patients need to stay in the hospital for a long time. We have patients staying into the hospital 3, 4 times. If at any moment you see that the patient is getting worse, okay, there is ethical debate if she's pregnant to terminate the pregnancy, okay? And we have done this once here in Saudi Arabia. A patient was about to die. She was in the ICU. She was not improving with all these conservative measures. So we had to terminate the pregnancy to remove the HCG so that she can continue on with her pregnancy. Okay, so this is the management really for OHSS. I'm ready now for questions before we carry on. Any questions? We do not need to keep the patient MPO, no.
Is it right to give citrotide injection?
No, so this is a new philosophy. I don't know where it came from. So some people say that if you give citrotide after the ovum pickup for 3 days, their condition might improve. This is ongoing. I cannot say it doesn't work, but there is no evidence for doing that at this stage for these patients, especially if these patients are pregnant. If you continue giving them citrotide while they are pregnant, you're putting their pregnancy at compromise. Regular diet, yes, you put these patients on regular diet. There is no need to put these patients MPO. Is ovarian drilling prior to stimulation in patients of PCO one of the methods to reduce OHSS? Absolutely not. Ovarian drilling is something from the past. It should not be done anymore. Ovarian drilling has been reported to cause ovarian failure, okay? It causes premature ovarian failure. So there is no role for ovarian drilling in modern day practice. Remember, when you are doing IVF, you are doing drilling. The IVF is the drilling process for them, okay? You do not give diuretics for these patients, okay? Another common mistake that I see, you see that the patient is overloaded, she's oliguric, and you're like, well, I need her urine to come out. Guess what? If you give her a diuretic, you'll put her into acute renal failure because there's nothing inside her vessels to pee it out, okay? So there is nothing inside the vessels that diuretics will help her to pee it out. Once the fluid starts to shift back into the vessels, the patient will complain from polyuria. She'll tell you, doctor, I'm peeing like a horse now, okay? So I don't usually, so that's one issue. NSAIDs in early pregnancy not allowed. Yes, we do not give NSAIDs. I do not give it throughout the pregnancy because of the detrimental effect, namely on fetal kidneys. It causes oligohydramnios, and there are some studies that it might affect the heart, okay? It can cause also patent ductus arteriosus. Why is NSAIDs contraindicated? Again, we said them as the issue. The other important question I'm receiving here, why don't you advise albumin? So in guidelines, it is written, and I don't object giving it to the patient. However, it is a blood product, and 99% of patients with all of these conservative measures that we talked about, they will improve with time without the use of a blood product that most probably most patients will not need. The target hematocrit for me is below 20 usually. If it's below 20, I'm happy and I let the patient go, okay? I got another question. How do you manage patients with OHSS? And according to experience, how long do they stay with OHSS? So this is how I manage my patients. Mild to moderate, I manage as outpatient. Severe, I manage them as inpatients. Most patients will require a week. Patients with severe OHSS, they will flip out of OHSS and go back to their normal status. Okay? Other questions? So Zaina is one of the doctors that works with me. We work in a center with multiple doctors working. Alhamdulillah, knock on wood. We had the target when I was doing my fellowship to eliminate admissions for OHSS. And we haven't had a single admission in the center when I was a fellowship. Since I came back to Saudi Arabia, again, knock on wood, I have not had a single patient admitted with OHSS to the hospital. I haven't actually had patients with moderate to severe, alhamdulillah, another fadlallah taban. Cabergoline dose, 0.5 milligram, 2 hours before the ovulation trigger, continuous daily for 8 days. If she's too nauseated, you can give it to her vaginal. Vaginal cabergoline is equivalent to oral cabergoline, okay? Mortality rate, if patient is in severe OHSS, the reported mortality rate is anywhere from 5 to 20% looking at the studies, different studies. Alhamdulillah, with the modern medicine, things are going well. The last thing you want to do for these patients is open their abdomen. So in some centers, because of the severe fluid they have, they're like, okay, let's go open the abdomen, try to drain the fluid, take a slice of the ovary. You will kill the patient if you open the abdomen of these patients, okay? I have a bonus question at the end. Can a patient develop spontaneous OHSS? I explained this in one of my lectures. How can they develop spontaneous OHSS? Any smart person to tell me. Under what condition you should think about if the patient presents to the ER with multiple follicles, fluid, typical OHSS picture? No, haven't received it yet. So in patients with FSH adenomas, okay? So if she has a pituitary tumor that's producing FSH, okay, all the time, it's like she's doing IVF all the time. So she comes to you at that stage presenting with OHSS, and the treatment for them is not surgical. It's the same as we mentioned here, but we suppress them with GnRH agonists, okay? When you give them GnRH agonists in these patients, you have to remember the flare effect. So if you give them the GnRH agonist with FSH adenoma, you will cause her to ovulate all of those follicles that are sitting right there. I actually had 2 patients when I was a fellow. I haven't seen it in Saudi Arabia yet. The first patient, we gave her GnRH agonist alone, and she flipped into severe OHSS. She almost died on us. So what we learned is when we give them the trigger, GnRH agonist, we give them letrozole with it. Letrozole and cabergoline. Letrozole will reduce the amount of estrogen in her body, and the cabergoline will reduce vascular endothelial growth factor, production. I think we stop here. It's 11 o'clock now. Thank you very much. Any other questions? Maybe Dr. Haytham can come back in.
Marhaba, ahla wa sahla. Thank you very much. Very, very nice lecture. I've enjoyed it so much. So I'm all yours. If there's any questions, you can address it to Dr. Ayman. Perfect.
Okay.
Looks like there are no questions. Then hopefully, please, for the next upcoming lectures, thank you very much, Dr. Ayman. I really appreciate your beautiful lecture here. And everyone, guys, please register for the next lecture from now. Please register for the next lecture from now, because people are registering while the lecture is running, and they're finding the difficulty in entering the lectures. So the earlier you register now. Each lecture has its registration link, so you have it smooth, and you can really enjoy the lecture from the beginning. Hopefully you're going to find the link of this on YouTube, inshallah, and on the Twitter account soon. Thank you very much, and have a good night.
Have a good night, everybody. Good night. And soon, inshallah, Dr. Haytham will keep you posted about the ovulation part 1 and 2. Okay?
That would be lovely. Thank you very much, Dr. Ayman.
Good night. Good night.